Thanks for being all here. My presentation about acute bleeding and my conflicts of interest and disclosures. So I will briefly go about some background, prediction of bleeding, prior interventions, prediction of bleeding during intervention with, of course, focus on cardiovascular and prediction of severity of bleeding. So first of all, just to get everybody a bit awake after lunch, how good are you in predicting? So what do you think is the amount of blood in those gauze? You see it's 10 by 10 centimeter. Do you think from left it's 100 ml to the right to 20 ml, or is it more like 80 on the left till 15, or 30 till 5, or 20 to 2.5? So what do you think? Who is for number 1 as an answer? Alrighty. Number 2, number 3, number 4, okay, almost normal spread in the room, but it is number 3. So it's 30 ml, 20 ml, 10 ml, and 5 ml. So the other one is this, of course, you're being called in OR in the ICU and there is a mess and you think like, okay, this is really something going on. But what is more blood loss, A or B? So who thinks number 1, A is more than B? And who thinks number 2, B is more than A? Oh, you're doing so good. You're doing so good. All right. So it's the other way around. So at the end of the presentation, we will get why people think this way, because it's a common mindset. So the other thing is how much is here in the bed or on the ground. So do you think it's a liter on the left, or is it even 3 liters? And on the right, it's 750 or up to 2 liter. Who think number 1? Number 2? Number 3? Number 4? All right, so it's a bit between number 2 and 3. It is 1501 liter. All right, so we'll get back to that. So, and why? I mean, it's fun, of course, to have a bit of interaction and get awake a little bit. But why is it important? Because most of the guidelines, they guide you on the amount of total blood volume loss to start doing things. So if we are even not able to guess right, how should we apply those guidelines? And we should be aware. So we need to do better than this guessing. I mean, we can train you a few more hours on all those pictures, but there are other solutions. So we could do it, of course, already before the intervention starts. Before the blood is out of the patient, we could already have a prediction on how much this patient is going to bleed. And why do we think this is important? Because it creates awareness for the whole operation team. We might already do some interventions beforehand, but also, in the end, we need trials, whether a certain intervention works or not, and then we need enrichment for a certain patient population, of course, at risk of bleeding, because if we start doing trials in patients that will not bleed or will have no complications, you will probably end up with many negative trials, and we already have too many negative trials. So use your information. The information is there already. Do maybe additional testing. So this is the group of Gavin Murphy in the UK. He has used large databases to see whether, on information already available before the operating, whether you could do prediction of any red blood cell transfusion in a cardiac surgery patients, or a large volume of at least 4 units of red blood cells. So a prospective data set of several consortia, summing up to almost 40,000 patients in which it did an internal validation. What you see here is that this is the standard data we all have in our electronic patient files. We've got sex, age, preoperative hemoglobin, whether the patient has endocarditis, whether the patient has an IBP, all this thing is available. So what they did, they pulled the data set, they did imputation if there were missing data, and then they looked at large volume blood transfusion or any red blood cell transfusion. Here again you see all those variables which are associated with the onset of any red blood cell transfusion need or large volume transfusion need. And here you see the area under the curve, and it's doing quite well. On the left top you see overall with an area under the curve of 0.77, but for large volume blood transfusion even 0.81. So actually we know already before the surgery starts this patient will be in trouble. But often we are quite surprised the patient is in trouble. And it's also available, the risk score, you just can enter it online and you already have this risk factor, how problematic your patient will be. And here you might get this personalized, individualized approach that you might withdraw anticoagulants, or you might do more cell saving, or you get your preoperative anemia controlled. So this is another thing, measuring when you're already confronted with the setting, because the previous was mainly elective, so here we've got time, but we all are also faced with those acute STEMI patients need for emergency cabbage, and I mean, we would love to improve things, but we cannot. So what they did here is viscoelastic testing assay. Prior, the patient was going on pump. We always use it when the patient starts to bleeding, but we never do it beforehand. It's an observational study, emergency cabbage on Ascal and clopidogrel gel, viscoelastic testing, and outcome post-operative, the amount of chest drain. And what you see here is the mean clot firmness was predictive for the volume of chest tube drainage. And then you might think like, okay, so what? But we start getting interventions, the antibodies are underway for antiplatelet therapies, which we might be able to infuse in the patients that are at risk for bleeding or during bleeding. So in that way, this kind of tools are going to help us to stratify the patients where we need to do those interventions. So those risk models will help us doing new interventions trials. The other thing is, of course, important that those risk models are incorporated in our electronic patient files so that if we have this patient in front of us, it's automatically already entered and you get your information. So the other thing is if we are even in the surgery, so we have now done the outward patient, we've done the emergency, you know this patient will be in the operating theater, but when you're already during the surgery, and how can we then predict? So big data, machine learning, I think is going to help us here. We of course love to be experts, but what you see here is a paper in JAMA, and it's nicely giving this overview where we as humans are. You see the black dot below. If you have a very long lifetime as physician, you can have a lot of observations, but you will never beat computers or big data. So we need to trust them. On the other hand, machine learning, big data, I think it's mentioned already. In the 1950s, we already had the first papers on machine learning and big data. So we do like it's something very novel, but it's just a part of our statistical analysis plan we have, and this is also very nicely written in this paper. So, but this machine learning, it might help us. This was studied and published in Lancet Respiratory Medicine for cardiac surgery. Maybe a bit strange, you will not search maybe in Lancet Respiratory Medicine for cardiac surgery cohort, but it was published there. And deep learning methods in cardiac surgery with internal and external validation and the outcome prediction of complication. And what the good thing was with this system, it used real lifetime the data of the EPD, filling the model and giving back the prediction. And here you see the positive prediction and sensitivity scores, so really good for problems like mortality, renal replacement therapy, or major bleeding. So it uses existing clinical data, directed admission. In this setting, there was no data entry necessary, so I saw some pictures people taking from this risk score from the UK, but actually your perfect setting would be that it's incorporated in your patient system. Of course, the big question mark is that if we know the risk, if we can predict the bleed, we need to have some solution for this patient group, and this is of course what we need to do with trials. And of course the other danger is self-fulfilling prophecy with this kind of models, that if it's predicting and mainly of course with mortality, for example, in the most extreme with the machine learning, if it's predicting mortality and we're not going to do anything because the system says the patient will die, it will always die and we will never get an improvement in the system. So this can be the tricky of this kind of system, but in the end I think it will bring us more good than bad. Prediction of the actual bleeding, we discussed already a little bit, but hypertension is often a symptom of bleeding, but often it occurs already when it's happening, when the issue is really there. So it's a reactive treatment, the patient is already crashing, and then we start doing things. So what we would like is that we actually already are warned something is going wrong. And especially with young patients, we know that they have so many compensatory mechanisms that they will keep their blood pressure properly, and you will not find many hemodynamic characteristics that predict this patient is going bad. So early signs of hemodynamic instability, that would be lovely to have, and here maybe AI might help. So although maybe you are aware of this, it's HPI, the Hypertension Prediction Index. It is mainly used for hypertension, but you could think about it. Such kind of system might also help us in predicting the patients that are bleeding already. What it did in a machine learning model, it trained on hypertensive events, and the computer looked back in the waveforms whether there were already features up to 20 minutes back which are associated with the event occurring. So there were more than 2.5 million features in those waveforms. So we are all brilliant physicians, of course, but we are not able to detect 2.5 million features in waveforms. So computers can do that. Here it was also trained, very important, I think, that with all those models we need to do a training set, we need an internal validation, we need an external validation, and then even we need to show that adding an algorithm on top of standard care really results in improved outcome. So here you see there's a beautiful sensitivity specificity. It is really minutes before the events. It can already predict your patient is going to be hypertensive. This is kind of system, it works, but we could, of course, think about many other systems as well. And, of course, what is important, can we find the cause already why this patient is becoming hypertensive? So this would be the ideal picture, I think, in an operating theater, that there is a machine learning-derived algorithm that is already going up, that's at the bottom. Your patient is going down, but it's already alerting you prior that the patient is having really problems. So what would be important? Those machine learning-derived algorithms are already tested in general hypertensive events, but specifically in those high-risk bleeding patients, it might be of interest to see whether it would help us to identify already early those patients that are bleeding. And maybe you think it's a bit silly. Of course, you're in the operating theater, you see the patient is bleeding, but especially in cardiac surgery, we are faced often that the patient is bleeding at the backside, for example, and people are not aware the patient is actually already bleeding, and then suddenly the patient really crashes. So the severity of bleeding, I was already mentioning it a little bit. We are used like open chest, everybody can see everything, but we're getting more minimal invasive surgery. So in the past, where we really had some good sight at the operating field, where you could see, oh, it's going to be very bloody, now we have small entry sets where small cameras are, and there the surgeon is busy, and you as an anesthesiologist, you are just, well, in a way, in the dark and waiting for the patient to crash. So in this way, it might help us. Because the simple things like heart rate we learn in med school, you just can flip a coin. It is not helping you. Maybe in some sub-patients on the right top, you see when the patient is very old or the blood pressure is already very low, then heart rate starts to help you a little bit. But in general, in the early signs, it's not going to help you. So this estimation where we started with, why is it so difficult? It was studied, and I gave you the same test as other physicians had before. Only 8% of physicians are accurate. So don't feel bad. I think you guys did quite well. But only 8% within 20% of the actual volume, and 25% within 50% of the actual volume. So, and what is the problem we are facing? General small volumes are overestimated and large are underestimated. And surveys results in under and overestimated. So on the picture you had like carpet and concrete, which results in underestimation, but the moment you get clothing on, everything is in blood, then people start to overestimate, but really significantly up to 200 to 300%. So if we cannot do it, maybe a computer can do it. So what is already being developed is also a machine learning tool to see whether we can do this better. It was in a prospective multicenter study. It was abdominal surgery, but of course in cardiac surgery it could be done as well. Comparing manual rinsing, so really getting all the erythrocytes out of the gaze and sponges, and a gravity method where you were waiting, or with an imaging method using deep learning technique to determine the volume of blood loss in those sponges. So in which the rinsing is the gold standard, because then really everything is getting out of this gauze, and the weighting is actually what is done after now if people want to have a guess of the blood loss. And outcome accuracy was a measurement of hemoglobin mass on those surgical sponges. So this is the way it works. You just put your gauze in front of the screen, and it determines how much blood is in it. So, and this is where the deep learning and the machine learning is already very advanced. It is just training, the same we know from all the Google and Facebook things on what's in the image. It needs a lot of computer power, and this is also, I think, why this machine learning AI is really jumping now into clinical practice, because computer power and data storage has enormously increased. Availability of electronic data is there, which was different in the 1950s, of course. Here you see with this trial, this system really improved determining the amount of blood loss, while this weighting was really not accurate. And of course, it also saves time. You just have to put it in front and you know the answer. So management of the acute bleeding. So we could do, of course, a long story about that, but I think we have nice guidelines now, also with the European Society of Intensive Care Medicine. There are several other specific fields, of course, where also guidelines are. So please use them, of course. But I think in the acute, and in a way we also mentioned there the massive bleeding, because an acute non-massive bleeding, well, it's a bit strange wording. So if we really have this massive bleeding, well, we say start at least one plasma with 2 red blood cells. But of course, the most important thing is stop the bleeding. A transfusion is never solving the underlying problem, especially not post-operative. So you really need to stop the bleeding. Of course, if you're testing, you do point of care to see whether there is some coagulation deficiency you can solve. If that's not, and that's I think why point of care testing is also so important, to convince our surgeons that they are really in need to solve the problem. The other thing is, I think with transfusion in those acute massive bleeding patients, we have those massive transfusion protocols. We do need to realize that they are based on flawed data. So we had the data of Iraqi and Afghanistan war, where the Holcomb studies were observational studies. They showed this too good to be true reduction of mortality of 76% to 90% if you give a high plasma to red blood cell transfusion ratio. But the thing was, there was a flaw, because patients that died within 45 minutes, there was a lot of discussion whether you should enroll them in the trial or not. But at that time, plasma needed to be thawed before you could give it. Thawing time was about 45 minutes. So what do you think, guys? Should you put this kind of patients in your trial if you want to investigate the effect of plasma on outcome, or should you not? Who thinks we should put those patients in the trial, in an observational study? Who thinks you should not? To see whether you're still awake. Okay, so there are at least people awake. So indeed you should not, because if the patient is dying within, for example, 30 minutes, it will never be able to receive plasma because it already died and the plasma was not thawed yet, so you could not access this plasma. So this is confounding by indication or survival bias. Beautiful studies have shown that if you do a time-dependent analysis, the whole survival effect is gone. No other trial afterwards showed that this high plasma ratio was really saving. The proper trial is negative, and definitely we were not able to find those huge effects of 76% mortality to 90% mortality. What the scary thing is, a bit long introduction for this slide, is that 90% of the massive transfusion is given now in non-trauma ICU patients. So we should be aware of that. And I think it's good to bridge, but it's not the solution. And I think the protocols there are very important. this is something I would vote for. Conclusion, we as physicians are not good in guessing risk and severity of bleeding in patients. We can improve our guessing using scoring tools and machine learning. Screening of patients at risk is important to optimize them prior to surgery. Stop the acute bleeding. Transfusion is not a solution, it's just buying your time. Feedback, point of care after transfusion, very important. And future research needs to be focused where the machine learning and clinical practice and decision medicine can improve outcome, and interventions in patients at risk. If we identify, how can we improve them? Thank you very much.